It's my tremendous pleasure to introduce our first keynote speaker, Dr. Patricia Areán. Dr. Areán is a clinical psychologist and professor in the Department of Psychiatry and Behavioral Sciences at University of Washington, as well as director of the CREATIV Lab and the NIMH Alacrity Center. She is widely known for her groundbreaking work on the recognition and treatment of mental disorders in older adults and minority populations, including the use of digital health tools for improving access and engagement among communities that are historically underrepresented in mental health research and care. So please join me in welcoming Dr. Areán.
Thank you, everyone. It's a pleasure to be invited to present at this conference. What I'm going to be talking about today is just giving a really quick overview about the current database and knowledge around digital mental health. And in talking about some of the research methods we've used with remote research participant recruitment and the study of digital mental health tools, I will be talking a lot about what populations we've been able to reach through this kind of research methodology, which populations we are missing, and then to spend some time talking about optimizing engagement in research and in digital mental health tools. So it's no surprise, everybody who's on this, who is participating in this conference probably knows that we are in an era where we have an unprecedented opportunity to really peek into the lives of people at a daily and a momentary basis. A majority of the population across the world owns or has access to a smartphone or wearable device. And for many communities and many people, a smartphone is their primary link to the internet and to anything digital. This is also articulated by the fact that there has been a huge proliferation of digital mental health tools available on the market, with no less than 1,500 mental health apps. And during COVID, there has been a documented 30% increase in the use of digital mental health tools. And so when I talk about digital mental health, it's important to know what I'm talking about and which tools currently have an evidence base. In fact, digital mental health has been around a long time. Telemedicine is actually a very archaic but very useful form of digital mental health. And what I mean by that is the use of Skype or kind of, video on demand type of, services and access to mental health professionals. Currently, that model has expanded to include the use of text and SMS technologies to access clinicians in real time or as close to real time as possible. There are mental health applications, and there are two kinds. There are self-guided, which means that a person downloads the app and they walk through the app's process to help them with their recovery goals, and guided apps where not only are the mental health tools available on somebody's phone or on their computer, but they also have access to a professional or a coach to help them utilize those tools. And then there's online communities. These are basically things like peer support groups that are moderated by experts to help people in their recovery. Now, these three types of technology have the strongest evidence base. However, there's a qualifier here that most of the research shows that guided mental health tools, guided apps, or access to a professional tends to have better engagement with people with mental health problems, as well as technically better outcomes. However, the data is starting to improve for self-guided tools, which I'll talk about in a little bit. There's a little less for online communities. There still needs to be some work out there. However, from the utilization data in the wild, in the field, these are very popular methods of managing mental health problems. Now, what's really exciting is that there are other tools that people have been developing, as for instance, therapeutic video games, the use of AI technologies like using Amazon Echo or other digital assistants to provide social connectedness, advice about health and well-being, as well as robotics and avatars. But I will say, for the perspective of what the evidence base is, those three types of technologies actually have the least evidence base behind them. And that's not to say that they don't work, it's just that we need more research. There's enough confidence around the evidence base for certain types of digital mental health tools that in This time last year, there was a Banbury meeting of a convening of experts in digital mental health as well as healthcare policy to discuss what would be the recommendations moving forward in support of these tools. These recommendations are going to be published soon in Psychiatric Services, but essentially the message is that there is ample enough evidence out there to support the reimbursement of certain digital mental health tools, self-guided mental health tools, I mean, not self-guided, guided mental health tools, and that we don't really need to keep iterating on the tools that already have an evidence base, that if there's a new product out there, as long as it matches the standards or the principles that the evidence-based tools have, then that tool could also be considered evidence-based. However, despite all of the the positive news around some aspects of digital mental health, and the fact that you can reach an awful lot of people using these tools, there's still a lot of disparities in terms of the age groups that these tools are utilized by, reach with ethnic minority populations, and then even when you engage populations in the use of these tools, engagement, long-term engagement is actually pretty problematic. So just to give you an example, I conducted one of the first large-scale randomized clinical trials using remote research technologies to compare 3 different mental health apps or depression apps. And just to give you some scope, this was funded in like 2012. My sample size that I said I would recruit was about 200 people. And it was one of my first experiences ever where we launched the study on a Friday. I came back to work on Monday and was told we'd met our recruitment targets. So to reach 200 people in a period of 2 days was really mind blowing for us. We sought permission to continue doing this study to see exactly how far we could reach within the confines of our budget. And we were able to screen about 7,000 people and enroll 4,000 people over 2 waves of this study. And the ask of the participants was to be randomized to one of 3 apps, have them share passive data from their phones, as well as complete daily surveys about their mood and weekly surveys about their mood. And as you can see, we were really struck by how representative our sample was. It was obviously trending young because this is 2012, 2013. It's a younger population at the time were the ones most likely to have access to a smartphone. But when you look at the demographic breakup compared to the US Census estimates of minority status, in 2013, we were really close and we did not do targeted recruitment. The exception was the Latinx population, which was considerably lower than what the US Census estimates were. But it wasn't very hard for us to amp up that sample through targeted recruitment. So what we did was basically create specialized messages focused on community building. My 2 colleagues here are both PhD. One is a clinical psychologist, the other one's an epidemiologist, who both bilingual, bicultural, who gave messages about how important it is for our community to participate in this type of research. And these were aired over targeted outlets such as Spanish-speaking TV channels, news outlets, and so forth. And so even though we were able to amp up and get close to the estimates for Latinx populations in the US, we still were faced with a number of challenges in conducting this kind of research. For instance, even though this is a population, and this is true with a lot of low-income populations as well, not just Latinx populations, but smartphones are in use, but they're often shared. So if you're trying to do a passive sensing tracking kind of intervention or a mental health intervention, which carries an awful lot of stigma in the community, you will get early dropout because they're sharing their phone with another family member or somebody else in the community. There's also limits to the data plans that people have access to. And so the more data that gets scraped or used in a mental health app, the more likely this population is to dump that app in favor of the tools that they do need. And although telesurvey is still possible, a lot of very low income populations use temporary phones. And so you may have one phone number for an individual, but that might change in a moment and you won't be able to reach that individual. This is borne out in a study, large-scale meta-analysis that my colleague Abhishek Pratap conducted, where he took data from 6 very large-scale remote clinical trials. Not all of them were mental health. I think mine was the only mental health trial. And as you can see from I don't know if you can see clearly from these slides, but the purple dense population density just shows that majority of the sample came from states where there's a lot of technology access, tend to be higher income states, but was really underrepresented are states for instance, in the South, in the central part of the United States. So even though we're reaching large swaths of people, they're not, the representation across the United States might be very limited. So now I'm going to move down into like what engagement looks like. And what I mean by that is long-term engagement. And there are different kinds. There's engagement in the research study, and then there's engagement with treatment. Research engagement historically has been very low. Most people who sign into a study that is remotely driven drop out within 2 to 4 weeks of the trial. And for an epidemiological study, it creates problems, but not nearly as many problems as it creates for a randomized clinical trial where you start to introduce bias into the data. However, certain populations, once you engage them, are actually pretty good at sticking to the study. So for instance, older adults, people with a clinical condition who are very interested, in learning more about their condition, and people who are referred by clinics or by health providers are more likely to stay in a study than somebody that you recruit off of Google, search or Craigslist. This mirrors the use of technology in the real world. In fact, there was a recent meta-analysis, or not quite meta-analysis, but analysis of population use of mental health apps from App Store and Google Play, finding that actually retention is even worse in the real world than it is in research. And so we have a real problem with keeping people engaged in mental health tools. Now, there are strategies that we can use to help with research engagement. For instance, financial incentives work very well. In my study, we paid people $75 for a 12-week engagement. We kept about 50% of the sample in. I've been involved and consulted with a study, with the mood baseline study. The baseline mood study. We pay people more in that project, and we were able to keep about 75 to 80% people engaged. But you can't rely on finances and money as a sustainable method of engagement. So people have been exploring different methods. These aren't tried and true, but they're worth exploring, that not only could help people stay engaged in research, but also stay engaged with the mental health app. So for instance, having assessments work more like what you would expect from a phone. The first panel icon here is basically a survey where it looks like a chat feature. Another approach is to use non-financial rewards such as attaboys or gifts to kind of celebrate the fact that you completed a survey. Some people have looked into social altruism, that for instance, every survey that you take, 10 cents goes to a charity of your choosing. And then there are behavioral economic models where you can use tokens, you can use variable reinforcement principles to keep people engaged, like, you might get reinforced for, sticking with your app, every other week versus, weekly. So there are a lot of strategies that people are considering. But one thing we need to really think about is why are we trying to force people to engage in these tools when we don't really understand how they want to use digital mental health as part of their recovery? My colleagues in human-centered design and engineering have been studying this question for quite a long time. And in the health apps have found that there are these really interesting utilization patterns that people have with health apps. In fact, the engagement is actually pretty cyclical. So for as an example, somebody will download, will be searching for an app because in this instance, they want to lose weight or they want to control their diet. They have a variety of tools out there that they could analyze, and however they decide or make that decision to, try a tool might involve them trying a couple of different types of tools, particularly if they're free, and then electing one of them. And then as they're using the tool and they're working towards their goal, what happens is that they may no longer need the mental health tool to on a regular basis the way that we would expect them to. They have internalized or incorporated the principles of the app and are now using it on their own, and maybe come back occasionally just to double check, or if they start to, in this case, gain weight again, since they had success with the app, they might move to that one, or they may move to a different one, a newer app that a friend recommended. So just because they're not engaging with the app doesn't mean that this is necessarily a bad thing. And so we're conducting research, about to conduct a study now to study the different engagement patterns of people with mental illnesses who are accessing digital mental health tools, looking at what those engagement patterns look like and how they might map onto clinical outcomes. So, in short, future directions for research in digital mental health should focus on pursuing more large scale trials of different kinds of tools. And we should be thinking about how we can incorporate other types of data sources. But really, what's critical here is a better understanding of patients' views on the use of technology for well being, what they want to use digital mental health for. And it may not be a replacement for mental health care, but an adjunct to it, and a better understanding of what optimal engagement will be. So thank you very much.